Good morning, everyone. Good morning, Shilpa ma'am. Good morning, Dr. Prinja. Good morning, Abha ma'am. Sumit this side.
Morning, Dr. Sunit.
So, I would also like to take this opportunity to welcome Dr. Prinja to NHA family. Very warm welcome, sir. Sir, it's a request. Participants are still joining, so can we wait for 5 more minutes and then we can begin the session?
Sure, perfectly fine.
Okay, thank you, sir. Meanwhile, I will request all the participants if they have any queries, we'll have a Q&A session at the end of the session. So, any participants having any doubts and queries, they can ask their queries at the end of the session. Thank you.
Good morning, Abba. Good morning, Shankar.
Good morning, Dr. Sudha.
Hi, good morning, Dr. Sudha.
So, good morning, everyone, once again. Welcome to Nirantar Shiksha session. Today we are having a session on healthcare financing and insurance, and the speaker for today's session is Dr. Shankar Prinja, and the moderator of the session is Abha ma'am. I would request all the participants, if they have any queries, we'll address all the queries at the end of the session. So over to you, Abha ma'am.
Thank you, Suneet. So welcome everyone. Today's session is part of a webinar series being organized with Nirantar Shiksha in collaboration with PGI Chandigarh and IDSI. It's on use of economic evidence for decision making. And today, as Suneet mentioned, we will be talking about healthcare financing and insurance. Just an outline of today's session. So Dr. Shankar Prinja is leading the session, and he will be talking about healthcare system function and objectives, and then giving an overview of framework for financing health, uh, as well as speaking about risk pooling and what are the different methods of financing healthcare. In the end, he will be speaking about current healthcare financing in India. And as Suneet mentioned earlier, we will be keeping the last 20 minutes of the session for question and answers. But please feel free to put your questions in the chat box as the webinar proceeds, and we will try to take as many questions as possible at the end of the session. So I'll be handing over to Dr. Shankar Prinja for the session. I'll stop my screen share, Dr. Shankar, so that you can move the slides from your side.
Sure. Thank you, Dr. Abha. Just confirm me if once you see the full screen view of the slides.
Yes, sir, it's visible.
Okay, sure. Thank you very much. Thank you very much for this opportunity to be talking on this very important topic. And as we had some feedback from some of the stakeholders, what I'm going to talk about during this session, I'll try refrain myself from showing you a lot of figures, because I understand that you perhaps would be much more conversant with what is the level, evidence, etc. I'll try as much as possible in this session today to talk more in terms of the frameworks of financing and how do the different methods of financing ultimately impact on the health system's objectives. So that's going to be what I'll try to cover during this session. But as we have tried to outline a plan of discussing this very important issue of financing and insurance, the second webinar that we would plan, we will try and discuss more in depth on the challenges of an insurance-based system or a risk pooling-based system. And the third that we will try and organize, which would specifically focus on the issue of strategic purchasing and the provider payment rates. And finally, we'll touch upon the use of all of this in trying to develop health benefit packages. So as Dr. Abha mentioned, this particular session, I'll particularly focus only on the broader systems function and how does the financing impact on each of these objectives of the health system. So this is a framework of the health system that was outlined in the World Health Report in 2000, wherein actually for almost the first time there was a systematic attempt at trying to define what a health system means, because health system could mean a lot of different things, so even the care being provided by the mother to a sick baby at home, because the ultimate objective of that is the improvement of health of the individual, should be a part of the health system. Or let's say any intervention that you try and do in order to let's say reduce road traffic accidents, whether that is part of the overall health system's mandate or not. So this report basically tried to conceptualize what a health system is, what are its functions, and what are its objectives. And what we see on this slide in the yellow boxes on the left side are the different functions of the health system. And the gray boxes on the right side depict what are the ultimate objectives of the health system. What is it that the health system wants to achieve? So ultimately, the health system wants to achieve the best possible level of health for the population by providing services that are responsive to the needs of the community. That means they are of good quality, provided in a manner that is dignified, etc. and at a cost that does not impose too much of financial hardship. So whatever you charge to the patients in order to access that healthcare should be something that is contingent upon their ability to pay. It should not be way above their ability to pay, so that either they do not access healthcare, or if they access healthcare, then they face a lot of financial hardship. And in order to meet these objectives, there are these functions of the health system, which include obviously delivering health services by creating resources, which also include human resources. But an important function of the health system is financing or generating the resources to pay for all these services. And ultimately, there is an overall governance function. So one of the important things that came out of this report was that one of the important objectives of the health system and one of the important functions of the health system is intricately related to how you finance your healthcare systems. And this led to a very renewed interest among public health professionals, program managers, policymakers in trying to integrate the knowledge of financing within those who are working in the field of health systems. And then there was another subsequent work that was done by Joseph Kutzin, who works at the WHO, and he presented a rather more disaggregated framework of the same approach that was presented earlier. And he basically tried to outline that, the financing, so when you looked at the previous slide, it had just a linear flow and just one of the outcomes was being affected. But as you see here, there are certain intermediate objectives of your financing policy, which could include quality, could include equity, efficiency, as well as transparency and accountability. So these are some of the intermediate objectives. And then these are the long-term health system goals that you want to achieve, which is very similar to what we saw in the previous slide also. So achieving better health outcomes, the distribution of that health outcomes should be fair among people in different population subgroups. There should not be any financial hardship, and it should ultimately be of good quality, whatever care has been provided. So what you see here is now a much more intricate web of interlinkages between the different functions of the financing and some of the intermediate objectives and some of the long-term objectives. So this is just to highlight to you that there is this very significant importance of how you finance your healthcare services and what are the ultimate goals that you achieve in the end. Given this understanding, now let us move on to seeing what exactly do we mean by financing system. In a very simplistic manner, people earlier used to understand, whenever one used to talk about financing, people used to always take the connotation that financing means simply generating the money, or revenue generation is what is financing. But in reality, the overall financing system actually has 4 functions. The first function of which, as you see from the bottom, is collection of funds. And this is what we commonly refer to as revenue generation or revenue creation. So this is the first function of a financing system. But the second function of the financing system is that how do you pool those resources? Because ultimately you need to have in the financing system some kind of a insurance function also built into it. So that, and that I'll talk about a little later. And then the third function is that after having created resources and after having pooled those resources, you need to purchase healthcare services. So you need to, in our usual language, we say empanel service providers. So this is what we refer to here as purchasing of healthcare services, which also becomes a function of the financing system. And then finally, once you have contracted with providers in order to purchase services, then the final function is that the services are provided and the payer of the services pays a certain amount of money in a certain way to those providers. So each of these functions ultimately in totality determines the financing system. And at each of these levels, there is a strong linkage with the overall stewardship system, with the overall level of regulation that you try and bring about. And also there is a linkage with the population, because you determine that who is going to be, from whom are you going to collect the contributions? So that determines the first step. Then among whom or who all would you pool the resources? So who all are going to be entitled for the benefits of your financing system, or who all are going to get the benefits of your the services that you are aiming to provide through this resource generation. And then finally, the purchasing of the services will ultimately determine how much choice is available with the population in order to provide to access care. And also it will determine what is going to be the eventual coverage, etc. So, and at the level of provision of healthcare services and payment to healthcare services, there could be a linkage with the population. That means either they get a complete cashless system of accessing care. That means they don't have to pay anything, or there could be a system of cost sharing. That means there could be certain co-payments, there could be a co-insurance, or there could be a deductible. Each of these things ultimately mean that there is some kind of cost sharing at the end of the consumer who's going to access care. So this is the broad framework of financing that we have. And using this framework of financing, there is one essential function, that is one essential component that gets incorporated in a lot of these financing frameworks, and that is what we call as risk pooling. But before we go on to risk pooling, I just wanted to show you this slide to simply illustrate the point that why do you need risk pooling? And this is a slide that is drawn from US context. We do not have very similar data from India right now in the evidence, but the findings are not too dissimilar in any country context. Now, what this slide tries to show, the first bar is the overall population of the country. And each percentage shows you the cumulative share of the population. And on the right side, the bar represents the cumulative share of the expenditure that is attributable to each of the corresponding cumulative share of the population in the community. So what this means, if I try to explain to you, it basically means that the 1% of the total population in the US, which is shown in the very small line at the top, this 1% of the total population in the US actually, it contributes 27% of the total expenditure. If you come up to 5% of the total population, that means just 5% of the total people, they actually account for 55% of the total healthcare expenditure in the country. And if you bring it down up to about 10% of the total population on the top, then 10% of the total population actually accounts for nearly 69 or 70% of the total healthcare expenditure. So the point that we want to drive is that it is basically a very small proportion of people in the population that is actually likely to fall sick. And within them also, there is a small proportion that is likely to incur very high expenditures. So we basically want to create a pool of resources that is collected from all these people, because we know that these people who are at the bottom, they are not incurring any expenditure. But if they also contribute a certain amount of money into a single large pool that is created before you actually fall sick, then this money could be used to pay for healthcare expenditures of those who are falling sick and incurring the expenditure. So in a way, the risk pooling function actually tries to cross-subsidize the collections that are taken from the healthy people, and it is used to pay for the healthcare expenditures of the poor people. That is the most common mechanism through which there is a risk pooling. So the risk pooling takes place between the healthy and the sick people in any kind of a mechanism where you're trying to pool the risks. So the rationale, so how you want to pool the funds? You want to pool the funds between the sick and the healthy. So if everybody contributes, and there's a small proportion who are actually likely to fall sick, let's say 10% of the people are likely to fall sick, then having collected money from everybody, it ultimately means that 90% of the healthy people are also contributing a small amount of money that is ultimately going to be used to pay for the expenditure incurred by 10% of the sick people. And depending on how you collect this money, so if you are collecting this money through a kind of a tax-based system, so in a tax-based system, you collect the money in a way that is graded according to your ability to pay. So you charge, let's say, so you exempt the ones who are, let's say, up to a income slab of 5 lakh rupees. You charge, let's say, 10% of the income to the ones who are between the income slab from 10 to 5 lakhs to 10 lakhs, let's say. And then you keep on increasing this slab 20%, and then it goes to 30%. So in a way, you collect a higher amount of total money from the one who are the rich, and you collect a lesser amount, or maybe you actually exempt the ones who are the poorest from the total pool of money that gets collected in a tax-based system. So in such a system, there is actually a pooling of risks, not only between the sick and the healthy, but also between the rich and the poor. And that's why such a mechanism of pooling becomes a very good opportunity for redistributing resources or income between the ones who are the rich and the ones who are the poor. So it becomes, in a way, a mechanism to redistribute income or wealth between the society. And what are the advantages of such a pooling system? The advantages of such a pooling system is, A, it improves access to care, because the poor or the ones who did not have the means to pay for the healthcare services are now able to access healthcare. So it has a significant impact on improving the access. Secondly, the ones who go to access healthcare, it reduces their expenditures, and as a result, it reduces the catastrophic burden. And because the overall benefits are much more to the ones who are the poor people, it is likely to be likely to result in equitable outcomes as well. So the benefits of such a risk pooling system is likely to be disproportionately utilized more by the poor people, or in a way, the overall share of the public subsidy that you actually return back is disproportionately utilized much more by the poor people, more so because they are the ones who are more likely to fall sick, and they are the ones who contribute less. So it's the rich people and the healthy people who contribute, and the poor people and the sick people who utilize those resources. So that's the overall theoretical advantage. And given this background of risk pooling and the framework of financing that we tried and discussed, there are certain traditional methods of financing healthcare. And the 5 most common methods of financing are the ones that are listed up on your slide right now. There is a 5th mechanism also, which is prevalent in certain countries, which is called as the medical savings account, which is something that we've kept out of this discussion so far. The difference between, we'll discuss each of these in detail in the subsequent slides. But just to say, one of the differences, key differences between the first 4 methods that are listed on top and the last method, which is the out-of-pocket expenditures, is that in all the 4 methods that are up on top, there is a function of risk pooling. And the money that you collect is prior to occurrence of the illness. So it is a form of prepayment that you collect from the people. Whereas the out-of-pocket expenditure, there is no risk pooling. Each individual who falls sick is going to pay for his own healthcare, and he pays for that healthcare when he falls sick. So it's a kind of a post payment without any form of risk pooling. So that's the kind of broad distinction that you have within each of these 5 methods. And now I'll touch upon each of these different methods in each of these slides, and by and large, the pattern of discussion will remain the same. On the left side, I'll try and describe the kind of features of this method of financing. And on the right side, I'll try to present to you certain arguments, broad theoretical arguments, the ones that are the positives of these each of this feature, and the ones that are the sort of challenges, or you can say the negative points about each of these methods of financing. So let's look at tax-based financing. So we know that what tax-based financing is. So in our country, for example, in India, the entire health system in the public sector that we have established, starting from the sub-center up to the tertiary care medical colleges, all of this is the typical example of a tax-based financing system, because it is the government revenues that are used in order to pay for all these services that are being provided here. and the government revenues come from tax that has been collected. Now, the tax that you collect, there could be different typologies of the taxes that you collect. And the reason why I've listed 3 different typologies is because each of this different method of collection of tax or pooling of resources using tax money is eventually going to also have some bearing on what is going to be the extent of equity, efficiency, targeting of the method of financing. So the first distinction between the type of taxes that you might collect is between the type of resource that you tax or the type of revenue that you tax. So it's either a direct tax or an indirect tax. So direct tax is something that you levy on the income of the individuals, whereas the indirect tax is something that you levy on the consumption of individuals. Now, so the classical example of an indirect tax in India is something like the GST. Initially, we used to have the VAT. So this is a tax that is levied on consumption, whereas the entire IT department that is established is basically something that deals with the collection of the direct taxes. And so the direct taxes are levied on the incomes of individuals. And there is, in our country and in most of the other countries also, there is some degree of graded manner in which the tax slabs rise. So you tax a lesser, so the contributions are a certain proportion of your income. And that certain proportion of your income also keeps rising as you earn more. So it becomes a kind of a more progressive system, a more equitable system, because you collect more from the ones who are able to pay, and you collect less or you don't collect anything from the ones who are poor or the poorest. Whereas the indirect tax, although it still remains an equitable method of financing, but relative to a direct tax, it becomes less progressive, because let's take an example. So there is a rich person or a person who earns 10,000 rupees and a person who earns 1 lakh rupees a month. Both go to buy a packet of salt worth 100 rupees. Both end up paying tax around 5 rupees or 10 rupees, whatever it is. So irrespective of their ability to pay, because each of them consumed 100 rupees of goods, they paid the same amount of the tax. So irrespective of their ability to pay, there was no relationship with their ability to pay, and some form of indirect tax was collected. However, it is not to say that indirect tax is always inferior or less inequitable than a direct taxation. There are certain countries where direct taxes may not have a very steep graded manner in which you charge the incomes. Whereas in the indirect taxation, you develop the mechanism of charging indirect tax in a way that you do not tax the common commodities that are consumed by the poor people, but you tax a very high amount of money on luxury goods, things like Mercedes car or air travel, things that are likely to be utilized by the rich people. You tax it much heavier, but you don't tax the ones that are consumed by the poor people, for example. And in such case, you might actually end up in a system where your indirect tax may actually be more progressive than a direct tax. But in general, direct tax tends to be more progressive. The second classification is based on the level of pooling. So a tax that is collected, once collected, it ultimately aggregates. So for example, in our income tax, the income tax ultimately gets aggregated, or the tax that is collected is aggregated at the national level. And based on certain recommendations of our Finance Commission for tax devolution, there is a certain share that is devolved to either which remains with the state, which remains with the center, and there is a certain proportion that is devolved to the states. And in the recent 15th Finance Commission, we saw that there was a greater tax devolution that was made to the states. So that's one mechanism. So you have pooled money at the top, and then you allocate to different departments. The central government announces a budget in February, and it allocates to health also. So that's how health gets a certain amount of money. The Ministry of Health gets its budget. So that's a central pooling. If, on the other hand, the tax was to be collected at the state level or at a local level, let's say municipal corporation or the local bodies are collecting the taxes, and they are utilizing that money to run the healthcare services. So let's look at what is the difference if the pooling takes place at a much more macro level versus at a much more local level or a state level. The difference is if you are pooling your resources at a macro level, there is a much higher probability that you can still redistribute and equalize the risks between the different recipients of that revenue subsequently. So which means that you collect, let's say, 100 rupees at the central level. Now, how you allocate that 100 rupees, you could allocate a higher proportion of that money to, let's say, the EAG states or the states that have a higher burden of the health and disease burden. Whereas if you collect the revenue at the state level, one, the extent to which you are able to generate revenue ultimately is going to be determined by the amount of overall productivity in the state. So a state like Bihar would be able to generate less amount of revenue, but a state like Haryana or a state that has a much higher GSDP would be able to generate more tax base. So as a result, at the level of whereas the needs for provision of healthcare services, the disease burden per capita level might be much higher in a state like Bihar. So which means that if you create your risk pools at smaller levels, at local levels, they are not going to be as strong a mechanism in order to equalize the risks. So the essential function that we wanted to achieve of risk pooling, that is going to be much better if there is a much bigger pool of resources. And that's why we tend to argue that the lesser the fragmentation of risk pools, the lesser the number of schemes that you have, or the higher the level at which you try and aggregate the resources, the better it is in order to equalize the risks between different recipients and in order to make the subsequent allocations more equitable. The final way in which you could consider the tax-based system is that how you ultimately collect the tax and how do you allocate that tax. So one way in which you could do that is a general taxation, which is the case in our income tax. So you have the incomes being taxed, that money gets pooled at the, let's say, the central level, and the ministry, the finance ministry then allocates this money. This is a general revenue pool that is created. And this general revenue pool is used to give budgets to different ministries, whether it is defense or shipping or mining or agriculture or health and education as well. Whereas there could be another way in which you could levy the tax, and that's what is called as a earmarked tax or a hypothecated tax. So this tax is a tax that is collected for a specific purpose. So it's not a tax that ultimately gets pooled in a general revenue pool, but it's something that is collected to be utilized for a very specific purpose. So clear-cut examples of earmarked tax from our setting is something like, we had an education cess that was collected as part of a surcharge on your income tax that was then used to fund the Shiksha Abhiyan program. So that was an earmarked tax that we collected. And more recently, we have the tax that was levied for the Swachh Bharat Abhiyan, which is an earmarked contribution that is collected. And it is used specifically to fund a particular program. So that's an earmarked tax. Now, the relative advantage and disadvantage. The relative advantage of a general tax is that a general tax tends to be relatively less volatile to fluctuations in your income levels. So but that is subject to the criteria that health is a priority for the state. So which means that if health is the priority, and in a given year, let's say the overall revenue that the government has collected falls a little short, let's say in COVID times, for example, that's the best example that we have. So in COVID times, we saw that the economy went down. We saw Q1, Q2, Q3, Q4 figures coming, and they were projected as much lesser than what it was in the earlier years. But despite that, we had higher allocations being made to health sector because there was a greater need at that time. Whereas if you have an earmark tax, that means there is a tax that is a fixed proportion of income, but it was only to be used for healthcare, and that was the sole mechanism of financing. Then in times of COVID or in times of recession for that matter, with the overall economy going down, the overall amount of money that you can also generate through that mechanism goes down. So a general tax-based system is a more stable system in order to fund healthcare systems, provided there is enough priority that is also laid to health sector. But that's a disadvantage of an earmark tax. But earmark tax generally seems to be more acceptable to people whenever you add more tax. If you say that it is if the government adds more tax, generally the people don't like it. But if you say there's a new tax that is being levied, but that tax is going to be used to, let's say, improve the health services in your area or improve the schools in your area, generally the acceptance for an earmark tax tends to be better because people tend to see the corresponding use of that money being made to. So given this discussion, what are the arguments in favor? The tax-based systems in theory tend to offer a comprehensive coverage because there is the services are opened up. So for example, our sub-centers to medical colleges, in theory, they are opened up to anybody can walk in. There is no defined coverage for a given population group only. All services are supposed to be provided there. They are highly equitable because the way in which you have collected the tax money, it is very equitable. You don't charge thereafter to people who are visiting there. You can induce efficiency through gatekeeping because you define that which services are likely to be made available there. But again, this is likely to be theoretical because people may not, if you don't, so there could be gatekeeping in, let's say, preventive care services in our country, but there is hardly any gatekeeping in curative care. So people seeking needing primary care walk up to institutes like tertiary care institutes like AIIMS and PGI, and you don't reject a person who comes in and walks into your OPD. And because there are budgetary constraints, so there is obviously a strong cost containment opportunity within tax-based funding. The classical example of tax-based funding also comes from the NHS in the UK, which also offers, which runs through tax money. But what are the downsides? The downsides is that the entire rhetoric of using tax money to fund healthcare services is ultimately dependent on fiscal space. And fiscal space ultimately is dependent on three variables. A, the level of economy. So how rich a country is. B, within the amount of income that the country has, how much tax you can levy. And C, within the tax amount that you are able to create, how much priority do you lay to health department? And that's why you nowadays see that there is a lot of emphasis on not just looking at an indicator which is called as the proportion of healthcare allocations as a proportion of GDP, but also the healthcare allocations as a proportion of the total government budgets, because that's an indicator of how much priority is being laid on the health sector. And also the fiscal space is determined by the second factor, which I mentioned, which is the ability to raise revenue, raise taxes, and which is very much linked to the contextual reasons, such as how much of your population is in the formal sector, how much is the extent of tax evasion, how effective you are in order to ensure that the people do pay their taxes, the way they should be paying those taxes, etc. So that's a big reason why, despite all these advantages, you're not able to make the best use of it. And finally, the way the payments are done, the way the structure is created, there are relatively lesser incentives for efficiency. Although there could be, it's not that the system cannot be redesigned. The system can definitely be redesigned, but currently the way it is designed, it leaves relatively lesser opportunities for efficiency. Next, we move on to the second system, which is the social health insurance. Now, the classical examples of social insurance in India are the schemes like the CGHS, the ESI scheme, the Employee State Insurance Scheme, and the ECHS, the ones that is for the defense services. The classical description of a social insurance scheme is that the contributions that, when we said the tax-based contributions were collected on as a proportion of the income, the social insurance contributions are collected as a proportion of the wage of the individual. Now, in a very layman terms, wage might mean very similar to income, but in reality, the wage is not exactly similar to income, and that's where the key comes. What is the difference between tax-based system and social insurance systems on equity grounds? So as I said, this is a system where you collect a charge that is proportionate to your wage. So I said in the tax-based system, let's say between the ones who earn between 5 lakh to 10 lakh rupees of income, you charge them 10% of their income on as contributions for tax. In this particular system, the contributions that you charge are a certain proportion. Let's say they are 10% only, but that 10% is charged on your salary or wage. It is not on your income. Now, the difference between these two is that people may have sources of earning outside of their regular wage or salary also. And these sources of income are likely to be things like, for example, somebody has a large piece of land which has been rented out, so he gets an income on land. Or there is somebody who's invested his money in, let's say, bank fixed deposits or shares, or there are a whole range of new investment designs that we have nowadays. And any income that comes that on that kind of an investment, there is no contribution that is charged in a social insurance system on those kinds of income sources, because your contribution is only on the wage part. And as we know, who are the ones who are likely to have additional sources of income over and above their salary? They are the ones who are the rich people, because they are the ones who will have more extra sources of savings that they can invest, or pieces of land that they could rent out. So as a result, eventually you are actually exempting the higher levels of income of those who are the rich people. And in a tax-based system, otherwise, these incomes would have actually been charged not only at 10%, but at something like 20 or 30%, because they would have gone above that into higher slabs also. So in a way, the extent to which you are able to collect a higher amount of money from the rich people compared to the poor people is lesser in a social insurance scheme as compared to a tax-based system. And so, on grounds of equity, social insurance, although it is still equitable, it tends, because the contributions are still as a proportion of your income. So even there also the poor pays an absolute amount that is lesser than the rich person. But still, as compared to the tax-based system, it tends to score lesser on equity. The contributions that you are collecting are earmarked. So they're specific to health benefits. So that's a form of hypothecated tax or earmarked collection that you're charging for the health coverage. And generally speaking, the contributions are not just collected from the employees, but also from employers. And it is generally managed by some kind of quasi-public bodies, which may be at an arm's distance from the government. And maybe there may be some stake of the employer also and the employee also in the management of the entire program. So obviously, it's a mechanism of financing. It is a very known mechanism which prevails in a lot of countries, Western European countries, creates a very stable source of funding for healthcare, where most importantly, you do not have to compete for a share of public budget. So unlike a general pool of revenue that is used in tax, and the fiscal space determines how much allocations that you get for health department, here, since the contributions are earmarked, you don't necessarily compute, and whatever money is collected, you get that money. And it's progressive because it's equitable, because you collect an absolute amount that is linked with the ability to pay. But what are some of the downsides of such a system in a country like India specifically? One, social insurance systems are generally applicable for formal sector employees, because they are the ones who get salaries. They are the ones who get monthly some amount of money for the production of goods and services that they do. But in India, if you break down the overall productive workforce, there is less than 10% of the total productive workforce that is in the formal sector. The remaining 90% is in the informal sector. So despite all these advantages of a social insurance system, the overall impact that such a scheme can make, because the contributions can only be, by and large, established for collection from the formal sector, it becomes relatively limited in terms of its scope. It's, as I said, it is less equitable as compared to tax-based financing, although it still is better than the rest of the schemes that we will hear. and it may have certain administrative costs, etc. So those are certain other additional disadvantages, but I'll not talk about these because we'll talk about these in the subsequent lecture. The third is a community-based health insurance. So the community-based health insurance system is a system that you can understand from a very crude example that I like to give is like, you have a kitty. So in a kitty, what you do is that you like-minded people, they come together and they say, okay, let us all of us contribute 100 rupees or 1,000 rupees, and whenever any one of us needs that money, we will draw out of this pool. That's the principle of a kitty, and that's exactly what is the principle of a community-based health insurance. So there is a community-rated premium that you collect. It is not linked to your income level. It is not as a proportion of your ability to pay. You simply decide, we'll pay 100 rupees premium or we'll pay 10,000 rupees premium. And this is a premium that this is a contribution that we collect from different individuals, different households. And then you make use of this money in order to organize healthcare services. And generally, the kind of people who come together are people who live in a given community. There is some sort of background community cooperation, some kind of principles of self-reliance that they want to build in within themselves. And it is still a prepayment contribution that you collect. But since the level of money that you generate as part of most of the CBHIs is relatively limited, most of them tend to depend on an external source of funding also. So they have some kind of a philanthropic funding also coming in. There are a large number of such CBHI schemes that operate in India. A survey was done by the ILO about nearly 10 years back, I remember, and it had a count of more than 150 community-based health insurance schemes. And interestingly, a lot of these health insurance schemes are located down south in the kind of coastal belt along the eastern and the western part of India. So all these schemes, such as starting from Seva in Gujarat, Accord scheme, Yashaswini, all of these are community-based health insurance schemes. So the advantage is that it tends to create some kind of a risk pooling mechanism for people who live outside of the formal sector. And since a lot of these pools are among people who are poor people, and then that entire money that gets used by those people only, so you can target the subsidies accordingly. But the downsides are more than the advantages. It's generally, often it is the scale of operation is small, and as a result, you do not foresee the role of CBHI to become a very sustainable mechanism of financing healthcare in any country, unless it is dependent on a major tax-based support system. The fourth mechanism of financing that we have is a voluntary private insurance. Now, this is a system which is the last of the risk pooling systems, last of the prepayment system, but where there is a major departure from all the other previous schemes that we had. So in all the previous schemes that we heard earlier, there were contributions that were being collected that were either a proportion of income in tax-based system or a proportion of wage in social insurance or a kind of a community-rated premium. But in a voluntary private insurance, the premium is actuarially determined. And what we mean by actuarially determined is that the contributions that you collect from individuals is linked to their probability of falling sick. So a person who has a higher probability of falling sick will pay a higher amount of money. A person who has a lower probability of falling sick pays a lesser amount of money. And a very crude way of determining what the premium would be is P times L plus this small l, where the small p is your probability of falling ill. So what is the probability of you to fall ill? The capital L is how much is going to be the expenditure that you will incur when you fall sick. So that's the amount of money that the insurance company will have to pay in order to take care of your health. And then this small l is the loading cost or the administrative cost of managing this insurance, of enrolling you, of managing your claims, of settling your claims, of ensuring that there is no fraud, moral hazard, etc. So this is how the premium is determined, and that's a major departure from all these previous schemes. So if you look at who the major determinant of the extent of contribution that you make is the probability of you to fall sick. So who is the one who is likely to have a higher probability of falling sick? The higher probability of falling sick is for the one who is likely to be elderly, because they are the ones who are likely to fall sick. The probability of falling sick is likely to be more for the ones who are poor people, because they have poor social determinants of health. They are more likely to fall sick. It is also likely to be more for, let's say, the very young children also, because they at this age are more predisposed to infections, etc. So in a way, the premium is likely to be high for the ones who are actually having lesser incomes, either the old people who don't have means of income unless they have some pension, or the ones who are the children who are not the earning members of the household, or the ones who are poor who have lesser income as compared to the rich. So in a way, a voluntary private insurance on equity scale tends to rank lowest among all the other risk pooling mechanisms. So while it increases, it definitely is a risk pooling mechanism, generates an additional source of funding. It increases the access and choice of services, because definitely the person who is insured does not face financial hardship when he accesses care, contingent upon obviously what are the cost sharing mechanisms, how much is co-insurance, co-payment, etc. And he can choose from the package that he has according to the preference of the health conditions that he's likely to face. But this scheme is likely to have the highest problems. It is likely to have, it is the most inequitable. Because of the voluntary nature, it is likely that there will be adverse selection, and we'll talk about this in much more greater detail in our next lecture actually. So I'll not place more time on this, but it's just to say that these are some of the problems that you are likely to have in a voluntary private insurance. So there's going to be adverse selection, there's likely to be more overuse of services, and depending on the level of co-payment, etc., it may continue to go up over a period of time, and premiums may go up because of adverse selection. And finally, we have the last method of payment, which is the out-of-pocket payments, which is the most regressive form of financing healthcare. There is no risk pooling, there is no risk prepayment. The entire payment is made at the point when you fall sick. So that's what is classical out-of-pocket payment. There are other forms of private expenditure also. Private expenditure means that the ones that are done by people without a kind of a prepayment. And these are things like cost sharing arrangements in risk pooling systems. So if there is a co-insurance, co-payment or a deductible in an insurance-based system also, that also gets counted as a private expenditure. So it has more disadvantages. You can see here, most inequitable, regressive, no risk pooling, no financial protection, limited access for the poor especially. Some people argue in favor of, for example, user charges in public sector. And they argue because user charges are likely to, discourage frivolous use of services and likely to encourage more judicious use of healthcare. But generally speaking, the argument, the evidence world over it points more to adverse effects of user charges, because it discourages utilization of even needed care also, and it has the impact is much more on the poor people, etc. So as a result, even if you believe that, even if some suppliers, mostly this argument is mostly given by providers, especially in the public sector, where they argue that there should be some amount of user charge, and that also gives them some additional resource at their disposal that can be used. But generally speaking, this is not a great advantage. There is another advantage of that is quoted of this system is that a person who is to make payment from his pocket can go to any provider. There is no embargo on him. But then the problem is that it is ultimately dependent on your ability to pay. So poor will definitely have much lesser choice and much poorer access, etc. So that's about the out-of-pocket payments. And this is just to summarize all of these. And I've tried to make the slide and try to make it more in Indian context. And it tries to show all these features, all these types of financing methods, and rank them order for each of these attributes. That means what is the extent of risk pooling, population coverage, service coverage, provider choice, potential to induce market competition, how much responsive are going to be the services, What is the potential to contain costs? And finally, how much is it likely for you to sustain the budgets for such schemes or from such methods of financing? So you can see clearly that ability to pool risks is highest in tax-based methods, no risk pooling in the out-of-pocket payments. Population coverage in theory, because by design you open it up to everybody, is there for everybody. In social insurance schemes, it is dependent on the context and the design. So what is the category of people who have become part of the pool? What are the services that you offer as part of the benefit package, etc. Service coverage, again, generally speaking in India, now here comes the catch. So in India, even if we say that there's a wide population coverage, the service coverage with tax-based financing systems, especially the systems that we have in the public sector that have been established, it depends on the allocation. So you may not have enough services that might be available on the ground. So effective coverage goes down. Whereas by design, there are services that are assured in a social insurance-based system, either through the provider or through the empaneled service providers, etc. So this is, again, I mean, this was just to summarize all of that, what I've already said. So I'll not again try to repeat all of this. But just to introduce you to another typology, because thereafter I'll try to put PMJY in context of all this discussion around financing. And that's that you also have another way of classifying all the systems, and especially the tax-based system of financing. So the tax-based system of financing could be classified in two mechanisms. One is, or the other systems also you can classify, but not to say that, but I'm right now taking more the example of a tax-based system. So any method of financing could be classified as either a supply-side financing or a demand-side financing. Or alternatively, there could be a mixed model as well. A supply-side financing, the classical example of supply-side tax-based financing is our public sector that we have established from sub-center to medical colleges. So what we have done is we have created a supply of healthcare services through the money that has been allocated to health sector. So we've created facilities. We are paying the staff salaries. We are procuring the drugs and consumables. We're putting in equipment, etc. And then waiting for people to come and access care. Even if nobody comes, that is there. But the more, if people start walking in, we start providing services. So it's a financing that is done to create the supply of healthcare services. Alternatively, we could also use the tax-based money to create a system of financing that is called as demand-side financing. So here, you don't create a supply of healthcare services, but now the money flows, the money follows the patient. And the classical example of the demand-side financing using tax money is the PMJY. So you don't pay your providers a salary. Neither do you pay them a certain amount of lump sum money to establish their facility. You simply empanel them and start paying them according to the footfall of patients in their facility. So the number of bypass surgeries that they do, the number of angioplasties that they do, providers get paid accordingly. So that's a demand side method of financing, that the money follows the patient. As many patients walk into a facility, the provider gets paid accordingly. And then there could be a mixed model also. So our ESI schemes, ESI social insurance scheme is an example of a mixed model, because you have the ESI hospitals, you have the ESI clinics, but then it also has a empanelment structure where it contracts out certain services to private providers and the CGHS as well, the CGHS scheme as well. So the patients can get referred from here to certain providers outside. They can get services, and those providers get paid according to demand side financing. So that's a very important consideration for anybody to understand within the Indian context specifically. And that brings us back to how we classify our PMJY or all these other publicly financed health insurance schemes that were existing in India even before the onset of the PMJY. So if you look at the entire tax-based public system or the publicly financed health insurance systems, the entire system of resource collection and resource pooling, this is our framework of financing as we introduced earlier as well. These two functions of financing are exactly the same as we had in our traditional public system. It is the tax money which is being used, and it is being pooled at the central level, or at some for certain types of taxes at the state level. The real difference between these two types of methods of care provision begins in the higher functions of financing, which is either purchasing or provider payments. So in case of a tax-based system, the care is provided by the public sector, where doctors are employed by the payer, and you pay them salaries. And anybody can walk in. There is a universal access, no, without any barrier. Anybody can come in and access the care. On the other hand, on this side, you have a set of providers from mix of public and private who are empaneled, and the money follows the patient. You don't create a supply side system of financing. It's a demand side system of financing. And you pay your providers for the care that they have provided in a manner that is targeted, because you only cover, let's say, 40% of the population that is as per the SECC list, or some other categories have also been added, but you don't say that everybody is there, although the intent ultimately may be to move more towards a higher population coverage. But most of the schemes have some kind of targeted coverage, either the BPL as the RSBY was there, and or likewise. And then the providers are paid according to the number of cases that they see or operate, based on some kind of case-based bundled payments. So essentially, if somebody asks that what is a PMJY in the broader context of a health financing system, a lot of people say it's a social insurance system, but it's not a social insurance. It's a tax-based system of financing healthcare, where you've created demand side, where you've created a purchaser-provider split. So now here there was no purchaser-provider split. The public sector was the purchaser, and public sector was the provider also. Whereas here the government is the payer, but the provider is a mix of both public and private providers. So there's the public purchaser-provider split, and there's a demand-side financing system that has been created to pay providers according to the number of footfalls. But in reality, any country, any state, the overall financing system that gets established is not clear-cut demarcated into each of these different individual methods, like simply a tax-based, or simply a social insurance, or simply a community-based, or a voluntary private, or out-of-pocket. In reality, this is the kind of picture that you have, where there is a very intricate, complex web of each of these different methods operating in the real world, and contributions coming from different sources. Different sources contribute. Different agents become the people who decide on how those payments are to be utilized. And there is a range of different types of providers. And this is an example of a kind of funding flow that we created when we did kind of a state health accounts for Punjab state. But this is the situation in almost all states. It's a kind of a generic classification that you could consider. So it's just to say that in no country, mostly, that there could be countries that may have predominantly a tax-based system, let's say like UK or Thailand or likewise. But it's not to say that even in those countries, tax-based is the only system of financing healthcare. There still continues to operate a voluntary private insurance in those countries. There might be still some examples of social insurance also that may operate alongside. So as a totality, there might be different mechanisms of financing, but it is important to understand that each of these different mechanisms of financing would have its own implications on the overall intermediate and long-term objectives of the health system. So finally, there's the last slide that I have, that there are certain, based on this knowledge of financing, there are certain very generic kind of lessons for moving towards universal health coverage. And these are some of the desirable, directions of reform that you would like to introduce, given the different elements or functions of financing system. So in general, it is always argued, and this is where we are also trying to move in the direction of the PMJY. We're trying to move from a lesser and lesser reliance on post payments and greater reliance on prepayments and compulsory sources of funds such as taxation, tax-based systems. We are moving towards, we are trying to reduce the extent of people who make payments out of their pocket and trying to move towards more and more of risk pooling based systems. We want to establish a mechanism of purchasing healthcare services that offers incentives or incentivizes the system towards having greater efficiency and greater quality. And this could be done through creating some kind of some pricing strategies or developing your health benefit packages in a way that it overall gets you the best value for the money that you're spending. And then talking about the health benefits and the rationing measures, there is definitely a need to promote the use of more cost-effective services so that whatever is being used, that's made best use of. There is greater value that is added to the overall health system. And finally, we definitely ultimately need an overall stewardship, oversight, and governance of the entire system. So thank you very much. I'll stop here, and I hope that I'll be able to stop my slide share as well.
Thank you, Dr. Shankar. There are a number of questions in the chat box, and I know we are 5 minutes over time. So maybe we could take questions for 10 minutes and try and conclude by 12:15.
Sure. I've just tried to open my chat box and it's still uploading.
I can read.
Now, yeah, please go ahead, please, Dr.
Sure. So there is a question from Mr. Kamal Kapoor, and he's asking, is there an issue with risk pooling that the rich sponsor the healthcare of the poor, but they're left out without any benefit? I know that may be specific to certain contexts, but maybe you could elaborate more on how risk pooling, even if the rich contributes, can also get some benefit.
Yeah. So, see, it's an interesting question, and there is a very fundamental underlying principles of social justice that need to be considered whenever we make such decision about it. So we ultimately want to create a society that is more egalitarian. And an egalitarian society would only be created if there is, if everybody tends to benefit from whatever development takes place. If there is a skewed development, then there is a role of the state in order to somehow equalize the resources. We do not want to make it a system wherein there are disincentives for somebody to perform better and become richer, but at the same time there is it varies from systems to systems. So if you go to a country like Germany, there is a very strong system, there is a very strong community social solidarity feeling that they have. They do not ask this question that we are rich and why should we pay more tax, and that tax ultimately gets used by the poor people. So I'll give you a very interesting example, and perhaps it will not take much time. You know, in social insurance, you make it mandatory for people to contribute. Social insurance pools can also have both rich and poor. So they felt that at some point there was very little consumer choice, and rich people might be feeling that they are paying contributions and poor are not, and they do not get the benefit because they don't fall sick as much as the poor people. So at one point of time, they said, okay, let's open it up. Let's give a window that if people want to opt out of a social insurance system, they can opt out. And they expected that the rich people would opt out because they'll feel that they can always pay out of pocket also if they fall sick, or they can have their own voluntary insurance. Interestingly, a year after they saw, there was hardly any movement out of it. And then there were a lot of people, social scientists, who tried to study that phenomenon. They ultimately said it's that feeling of social solidarity that did not make people feel that they're doing something wrong, or I mean, something wrong is being done to them by collecting tax money from them and that being used by the poor people. So I know that this is a question that is very fundamental, but the decision is ultimately based on how much of social justice or equity we want to achieve in our country context. And the response will always have to be based on consensus. It cannot be top down.
Thank you, Dr. Shankar. Just a follow-up question on this. Um, in India, the rich may be paying through taxes for the healthcare of the poor, but they may not be getting any benefit, not just because they are not falling sick, it's just that they may not be covered under the coverage of the scheme. And there is a related question over here which says most of the population in India falls in the category of middle class. What will be their contribution and benefits if it's a it doesn't necessarily, it's mentioned here rich versus poor risk pooling, but it doesn't necessarily need to be versus. It could be everyone pools. But there are questions that who gets covered, and do the rich or the middle class, if they contribute, should they also be covered?
Yeah, so I think that's a very interesting question. And frankly speaking, eventually we want to move towards that direction because especially in a country like India, there isn't too vast a difference between the one who is at the bottom 40% and even the one who is at the 70th percentile also. There is hardly much difference in their income levels. So in fact, if you look at the NSS data and look at the consumption expenditure of even the 90th quintile, 90th percentile, which means above that you have just 10% of the rich people in India. That has the per capita consumption expenditure of that 90th percentile, that cutoff, is about 1,500 rupees per month per capita, which means just about 6,000 rupees a month for the family, assuming that there's a family size of 5. So which means that ideally there needs to be a coverage for almost everybody. And because the poor that we are calling as, the rich that we are calling as rich are actually just 1% or even not even 1% or 2% of the total population. The rest all are like almost the same. So definitely there is a need to move towards that. It is going to be ultimately linked to how much resources also that we are able to raise. If we have enough resources that we are able to garner for the health sector, then definitely we want to have coverage for not just the poor, but also for the middle and also for the rich people.
Thank you. Thank you. There's another question which is about social health insurance scheme, and they're asking how does an employee with lower wages gets benefit from a social health insurance scheme? Uh, so maybe you could respond to that, and then I can add a follow-up question.
So in general, the social insurance schemes in India are actually meant to target the ones who are very poor only. So even within the ESI scheme doesn't cover all factory employees. Within the factory employees also, it covers only the ones who have an income level below a certain monthly income. So that's how the social insurance schemes are structured. But yes, the problem is, what about those poor people who are outside the formal sector? Now the problem is the entire governance structure of the social insurance is that you need to have earmarked collections from people who pay those revenues. So for those who are outside of the formal sector, the mechanisms to collect that money are very porous. So you may want to cover them. You want to cover the informal sector, but you don't get that opportunity, and that's why the only backup that you have is then the tax money.
Thank you, Dr. Shankar. To reiterate on the point that the proportion of contribution, if a person has lower wages, is less, but the benefits remain the same. So it's not that if they're part of the social health insurance scheme, they will get benefit even if their wages are lower. And you also answered another question that what happens to employees with daily labor wages, which is largely the informal sector. And they are then, of course, excluded from social health insurance if they're not part of some kind of formal structure for them to get the benefit.
Just wanted to add to this that when you say that in a social insurance, the contribution is lesser, but the benefit package is the same. See, the benefit package is the same, but the probability of a poor person within that risk pool also to fall sick is higher. So if the probability is higher, eventually when you do a benefit incidence analysis of how many people ended up eventually using those benefits, you might see the ones who are having poor social determinants of health, they are likely to fall sick more. And as a result, they access more healthcare services, they get the benefits of that risk pool more.
Thank you. There's a question from Priyanka Lalbani, and she's asking that can we find ways to introduce co-payment or deductible to have some control on abuse and to keep some kind of control on the expenditure?
Yeah. So it's a very thin rope to travel actually. So on one hand, we believe that any kind of user charge or cost sharing is ultimately going to be detrimental to access to healthcare also, and this detrimental effect is going to be more for the poor people. But on the other hand, we also do recognize that there is a problem of frivolous use of services also. So I don't say that there is no role of a co-payment or a cost sharing mechanism from the demand side. But what I'll add on is that, and we'll try to cover that in the next lecture, there are also supply side cost sharing mechanisms. That means you put the supplier at the risk of getting a loss. And people who manage insurance programs tend to find demand side cost sharing mechanisms like co-payment, co-insurance, etc., or deductible as more lucrative to reduce the supply of services. But the supply side cost sharing mechanisms tend to perhaps have a more welfareist impact on the population health, because they don't limit the access of the ones who are needy, but they limit the over provisioning of healthcare services by the suppliers.
True. And there are a lot of international health systems as examples for that.
Yeah.
So look forward to that further discussion in the next webinar. There are two more questions. One question is from Subhashri, and asking that one of the key contributors for out-of-pocket expenditure is outpatient cost. And how can this perhaps be included in the design for it to be covered under the insurance scheme?
Believe me, this is a question everybody is grappling. They've been, these are discussions on how to cover for, and this is a very pertinent point. There's discussions on how to cover outpatient care because that's the major contributor of expenditure, even since the days of RSBY. There had been few pilots. That's why, I generally also add on that, eventually whatever design that you choose in a given country is, although cognizant of the fact that there are these pluses and minuses of each of these methods of financing healthcare, but it is also very much to deal with the contextual reality of the system in which, or the setting in which you are operating. So in a setting like India, where there are so many large providers operating and large proportion of outpatient care is actually being delivered through your informal providers or even through chemists, or you go over the counter, you can get the drugs. In such a system, how do you effectively have a coverage for outpatient care becomes very tricky. So you don't have the bandwidth to empanel all those providers. And if you only say that outpatient care is for in hospitals that are your current set of empaneled providers, then the effective outpatient care coverage that you are giving is very low. So that's the trade-off. So I'm sure that we'll have some day that we'll progress towards. That's why I think everything will go together. There's going to be more regulation of the health system also, and we'll eventually perhaps reach to that stage where we'll effectively cover outpatient care as well. But definitely it's needed.
Thank you, Dr. Shankar. I agree. It's a complex question. So just one last question from Dr. Neeraj Agarwal. It's more of a comment and maybe you can add to it. He's saying that inclusion criteria in social security schemes like Ayushman should be based on economic criteria only, and rest should purchase health insurance. Government employees should pay for the insurance. For private sector, it should be mandatory for the employer to buy it for the employee. I don't know if you have any reflections or any points to share your opinion on this comment.
Sure. So I think that you are absolutely right. It depends ultimately, say, how much resources you have. So if your tax collection system is such that you're able to generate vast amount of money and you are able to meet the healthcare needs of everybody, then you may like to do that. But if you don't want to do that, but still at the same time, you don't want people to face the regressive impact of, let's say, out-of-pocket payments. And you need some kind of risk pooling system. So you may make some kind of mandatory contributions for those who are like relatively better off in your income strata, etc. And there are several country examples where such a system is done. So you have like even, I mean, US is not a very good system to take an example of, but then even in that system, which does not have a very good outcome, you have a Medicare and a Medicaid that still takes care of the ones who are the poor, the ones who are the disabled or the vulnerable. And they then try and mandate people to have voluntary private insurance, or the companies trying to bring about, the firms trying to insure their employees. But we'll talk about this issue of voluntary private insurance. You know, voluntary private insurance has very significant problems. So we'll talk about this in the next session, perhaps.
Thank you, Dr. Shankar. I wanted to ask if there were any last questions or comments from anyone before we conclude for today. Feel free to unmute yourself and speak out. If not, yes, do you want to say something? Okay. If not, Dr. Suneet, I'll hand it back to you to conclude today's webinar. And thank you very much, Dr. Shankar, and to all the participants for all the wonderful questions that you have put in.
Thank you so much, ma'am, and thank you, Dr. Prinja, for delivering such an well-informed session and describing in detail about various ways to generate revenues for health financing system. And I would also like to thank all the participants who have joined today's session. It was really a very enriching and lovely session. Thank you, everyone.
Thank you. Have a
Thank you very much.
Thank you very much.
Thank you, sir. Thank you, ma'am. Thank you, everyone.